Yes.
Good morning, everybody. Today our clinical meeting, the topic is HIV related respiratory diseases. Throughout the world, around 32 million people are suffering from the AIDS, and they are people living with HIV/AIDS. Out of which 90% are in developing countries. The patients who are suffering from HIV, that is the PLHA, patient living with HIV/AIDS, around 60 to 70%, they experience the pulmonary involvement, basically in the form of infections, particularly the opportunistic infections. Regarding the HIV, it is a retrovirus, HIV-1, and it has a unique enzyme, the reverse transcriptase, and it has a six structural genes, proteins, mainly the gag proteins, ball, and envelope proteins. HIV-2 has a similar structure, but it differs in the envelope protein. That is the main difference. And number two, HIV-2 is a very slowly progressive disease in comparison to the HIV-1. But recently, there are patients, documented patients, who are having the HIV/AIDS, but they are not HIV-1 positive or HIV-2 positive, just like the hepatitis B and C and non-B, non-C, like that. So this is a new entity where the HIV-1 and HIV-2 will not get, but patients are presenting with the HIV/AIDS. When the HIV infection enters into the body, it will particularly infect the lymphocytes, and as a result of which the T lymphocytes population, particularly the CD4 population, will decrease. Normally, our CD4 count is more than 925 or 930. The CD4 cells, they help in the T-cell mediated immunity. As the CD4 cell counts decreases, there is increased chance of opportunistic infections. Side by side, there will be increase in the CD8 count. That's why the CD4 by CD8 ratio will be changed. The main purpose of CD8 cells to
नहीं अब एकदम प्रेस कर देता है नहीं एकदम सॉफ्ट टच हाँ वो करके करो
Slide 1. नीचे से मार दी प्रॉब्लम इसी होना वाला है আমরা কন্ট্রাক্ট করছি সবাই নেক্সট বলো না স্লাইড শো में कुछ प्रॉब्लम है स्लाइड शो में
अरे उधर जाओ इधर से जाओ वन को आ जाओ इस तरफ
लेफ्ट साइड में आप उसको क्लिक
उसको करने आ उसके बाद करो उधर फाइनल फिक्स करो तो उसके बाद
हमारा इतना नंबर चल रहा था
तो जो भी पहला एक नंबर आ जाए
ठीक चला गया उधर वायरस ढुका ना ना ये इसके वायरस में वायरस
ऑटोमेटिक
CD4 का प्रॉब्लम
आइए
I will sit down this start तो उठा दे करो
कोना से करिए, कोना का है तो ठीक है।
So, CD4 count gradually it will reduce, and usually it is around 50 cells, CD4 cells per year. If it is more than 100 cells per year decrease, then it is a rapidly progressive course. So naturally, the main clinical findings or clinical things will depends on the CD4 cell count. So when the CD4 cell counts around 500,
वायरस है। अरे तुम्हारा पेन ड्राइव में वायरस था।
पेन ड्राइव में है ना, इसमें है
ये पेन ड्राइव से आ गया ये फाइल में सब वायरस नहीं थे, इतना सारे वायरस था इसका पेन ड्राइव में।
So when the CD4 cell count will be around 500, then there is a chance of this infection, particularly the bacterial infections, tuberculosis, herpes zoster, herpes simplex, and Kaposi sarcoma. When the CD4 cell count is
थोड़ा रिफ्रेश कर देना।
और किसका
रिफ्रेश कर दो।
रिफ्रेश
उधर राइट क्लिक करके रिफ्रेश करिए 2-3 मिनट। फिर भी हो रहा है।
उसका तो कंप्यूटर में एक भी वायरस नहीं हो तो किल कर देते हैं डेली हर रात।
तो उसको क्लिक मत
इसका पेन ड्राइव में बहुत वायरस था।
नहीं और एक बार जाके उधर क्लिक मत के स्लाइड शो में जाके
पेन ड्राइव से आप एंट्री करके ऑन करने से आ जाता है।
पेन ड्राइव बड़ी जबरदस्त सोर्स। हाँ, दूसरे का लगाइए अपना।
उधर नहीं करना शांत रहे।
अच्छा,
ऊपर जाके स्लाइड शो ऊपर
स्लाइड शो करने से ही खराब हो जाता है।
नहीं ऊपर जाओ ना स्लाइड शो।
यहाँ से
नहीं स्लाइड शो ऊपर लिखा है
हाँ।
सोफा ऊपर नेक्स्ट स्लाइड शो क्लिक स्लाइड शो
ये फ्रॉम बिगिनिंग
ना बस
कौन सा था ये?
ये थोड़ा
नहीं उसको बंद करते हैं रख लो।
So when the CD4 cell count is reducing, there is a chance of this opportunistic infections. When there is a CD4 cell count around 200 to 500 plus, then there is a chance of this bacterial, the tuberculosis, the herpes zoster, herpes simplex, candidal infection, hairy leukoplakia, or Kaposi sarcoma like that. When it is around 50 to 200, then there is a chance of this pneumocystis infection, pneumocystis jirovecii, and there is a chance of toxoplasma, cryptococcus, cryptosporidiosis, coccidiomycosis like that. When it will be less than 50, then there is a chance of this particularly lymphoma group infection. Most important is the CMV retinitis and the MAC, that is the Mycobacterium avium complex like that. So what are the common causes of the respiratory involvement in case of HIV infection? We have seen just now that it depends mainly on the CD4 cell count. Sir, good morning. So infections, mainly basically we can divide into two parts. One is the upper respiratory tract and there is the lower respiratory tract. In the upper respiratory tract, mainly there is sinusitis, whether it is a acute sinusitis or chronic sinusitis, mainly caused by this Haemophilus influenzae and Streptococcus pneumoniae. It may be viral, it may be bacterial, or it may be fungal also. Treatment is symptomatic, side by side the combined antiretroviral therapy. There may be upper respiratory tract, that is the bronchitis may be there, or there is a repeated infection causing bronchiectasis. But today our discussion basically on the bacterial pneumonia. The most common is the Streptococcus pneumoniae, just like community acquired pneumonia, Haemophilus influenzae, Staph, Pseudomonas, and another important is Rhodococcus equi. This is an opportunistic infection. Second is tuberculosis, and there may be other, that is the Mycobacterium other than tuberculosis. Most important is the Mycobacterium apium complex. Fungal infection, the important is Pneumocystis jirovecii. And viral, it is the CMV, herpes, and herpes zoster or simplex. Basically, the 90% of the respiratory tract infection is caused by these three rate, what I have done, that is the Streptococcus pneumoniae, tuberculosis, and Pneumocystis jirovecii. 90% of the infection of HIV is related to these three important causes. Non-infectious, most important is malignancy, because when the CD4 count will be less than around 100, then there is a chance of malignancy, particularly the Kaposis sarcoma, non-Hodgkin lymphoma, and Hodgkin lymphoma also, and bronchogenic carcinoma. Particularly, it occurs in the young patients because they are habituated to the smoking, recurrent infections, and HIV itself has some role in case of bronchogenic carcinoma. Non-malignant conditions like chronic obstructive pulmonary diseases, like pneumothorax, primary pulmonary arterial hypertension, like this pulmonary embolism, particularly the talc embolism. Talc embolism, it is due to the magnesium trisilicate. Particularly, it is seen in case of the injectable drug users. And there might be associated HIV pneumonitis. One is called the NIP, that is the non-specific interstitial pneumonitis, which is found in case of adult, and the LIP, that is the lymphocytic interstitial pneumonitis, is basically for the pediatric patients. So there are two types of interstitial pneumonitis. And iris, I will come to it later on. The most common infection is the opportunistic, that is the Pneumocystis jirovecii infection. Patient basically come with a history of this cough, which is non-productive but progressive. Usually it is a dry cough, and there may be associated this respiratory distress, fever, it is mild, and we have to diagnose the patient by clinically. It will be paucity of signs, that is, there will be some sort of scattered crepitations, that's all. There will be fever, clinically there is only scattered crepitations, and patient may have respiratory distress later on. We have to diagnose the patient by sputum examination for this Pneumocystis jirovecii infection. Sometimes the sputum is negative, then we have to go for bronchoalveolar lavage. But it is not possible all the time to do the bronchoscopy followed by bronchoalveolar lavage. Blood test, the most important is level of LDH, that is the around 90% is sensitive and 70% is specific. Around another important is, that is the new one, that is the serum beta glucan test, which is more sensitive and specific for pneumocystis jirovecii infection. So blood test we can do two. One is the LDH level, and the most recent one is the serum beta-glucan test. Sputum already I have told, that is either by the right Giemsa stain or the silver stain or DFA. And BAL already I have told, but sometimes it is not possible. X-ray chest it will show, I will show the X-ray. There is a perihilar infiltrates. There may be nodule formation, there may be parahilar lymphadenopathy, or particularly those patients who are taking this pneumocystis carinii prophylaxis in the form of nebulized pentamidine, there is a chance of this upper zone involvement. I will show you. As the disease is very notorious for killing the patients, it is divided into three groups, the severity. One is the PaO2 and SaO2 level. The mild, when the PaO2 level is around 11 kPa and SaO2 percentage, the saturation is more than 96%, then we have to treat the patient as mild by the cotrimoxazole, that is Bactrim GS or Ceftriaxone GS. And dose is either you take the cotrimoxazole contains sulfamethoxazole, methoxazole and trimethoprim. Trimethoprim either 20 milligram or sulfamethoxazole around 100 milligram per kg. So basically it is 120 milligram per kg in 2 to 4 divided dosage. But in case of mild, you should treat by the oral. In case of moderate, it is PaO2 around 8 to 11 kPa and SaO2 will be 90 to 95% or 96%. In that case, you have to treat by IV cotrimoxazole. And in case of severe, when the PaO2 is less than 8 kPa and the SaO2 is less than 90%, then you have to go for this IV cotrimoxazole plus prednisone. Sometimes the patient does not improve by this. Cotrimoxazole is the principal drug. But suppose the patient is not improving, then we have to go for this pentamidine isethionate. The dose is 3 to 4 milligram per kg per day over a period of 1 to 2 hours intravenously. Other drugs which you can use in case of pneumocystis carinii infection or jirovecii infection is this clindamycin. The dose is same, around 450 to 600 milligram 3 times daily to 4 times daily, plus primaquine. And if the patient does not improve, you can use oral dapsone plus trimethoprim or oral activapone 750 milligram twice daily. In severe cases, you have to add the steroid in the tapering dose, 40 milligram per day, 40 milligram twice daily in the 5 days, followed by 20 milligram, followed by 40, followed by 20, 50 reduction. This is a patient, HIV patient, PLHA, presented with dyspnea, non-productive cough. Patient was diagnosed as a case of pneumonia, a right middle of consolidation, and patient was treated by injectable antibiotics. After 7 days, patient did not improve, and there is bilateral perihilar shadows, and sputum shows pneumocystis jirovecii infection. Patient was treated by cotrimoxazole and improved dramatically. This I was telling. All the time it will be not the perihilar. Sometimes it may be in the upper lobe infection by the pneumocystis jirovecii. Particularly those patients who are getting the prophylaxis for pneumocystis jirovecii by nebulized pentamidine. This is bilateral perihilar consolidation. Prophylaxis. You have treated the patient, sorry. There are two types of prophylaxis. One is primary prophylaxis and there is secondary prophylaxis. Secondary prophylaxis means you have treated the patient by his cotrimoxazole or